Hello, good morning. This is Dr. Ahmed Haswan from University of Sharjah, College of Medicine. And today we're going to demonstrate the male genital examination. First of all, as we're used to, we're going to start with the introduction with the patient. The introduction will be just similar to all the physical examinations or any encounter with the patient, but we have to add one important point here. Now, because this is a sensitive and private examination, we have to ask for a chaperone. So if you ask what's a chaperone, the chaperone is just a third person that has to be in the setting of the examination. Now the chaperone could be a person who is a relative to the patient or a friend to the patient, so we can ask the patient if they have any preference. Then if not, then we can ask any colleague from the medical personnel to join the examination. So having said that, let's recap and do the introduction of the patient. So, of course, we have a mannequin. I'll imagine that we have a patient. So, good morning, sir. My name is Dr. Ahmed. I was assigned by my senior doctor to examine your genital organs. Is that okay with you? And please make sure to say the word examine and try to avoid using other words, because as we said, this is a private examination. So, sir, I'm going to examine your genital organs. Is that fine with you? So the patient will give us his consent. Now, please, sir, I would like to assure that the findings will be confidential between you, me, and my senior doctors. And do you feel the place is private enough for you? Okay. So, sir, I would like to ask you if you have a preference for a third person, a chaperone, to attend the examination. If not, then I will ask one of my colleagues to attend the examination. Is that fine with you, sir? Then once the patient says yes and gives you the consent, then we will start the examination. Now, as we're used to before we start the examination, we have to do 3 steps. So wash your hands, exposure, and positioning. So first of all, I will wash and sanitize my hand. Then, since this is an examination of the male genital organs, then I'll have to wear a sterile gloves. Now, regarding the positioning and exposure of the patient, now the positioning, the patient has to be lying supine unless we suspect or need the patient to stand up to check for hernias or varicoceles. But apart from that, the rest of the examination, the patient will be lying supine. Now, regarding the exposure, we try to minimize the exposure as much as possible. That's why we will not expose fully the lower limb of the patient. Rather, we will expose only until mid-thigh. Okay? So exactly till here. So before we start actually inspecting the male genital organ, we will take a general look at the patient. So first of all, we'll stand in front of the patient and give the general comment. So is the patient ill or well? So the patient looks well, he's comfortable in bed, he's not in acute distress. Now, comments about signs and symptoms related to the male genital examination, but actually it's in other organs. Namely, we have to look at the patient's chest, we look for the hair distribution, and we look for gynecomastia, since these two are direct consequences of testicular abnormalities or usually hormonal abnormalities, specifically the testosterone hormone. So the patient, he doesn't have gynecomastia, he doesn't have abnormal hair distribution. Now, we will now focus on the male genital organ. Now we will divide it into 2 parts. Examination of the penile shaft, then examination of the scrotum. Now for the penile shaft, we will start most distally and we go more proximal. So first of all, the first question that we should ask ourselves, is the patient circumcised or uncircumcised? Of course, in our condition and the mannequin that we have, this is a circumcised patient. Now, in the case that the patient is uncircumcised and there is a foreskin or the prepuce, so what we need to do is we have to retract it and we check the glans penis, so this is the glans penis, and we check the prepuce, which is the foreskin. Again, this is if the patient is uncircumcised. Okay, now sometimes we have a condition called phimosis. Now phimosis, if the foreskin is fixed to the glans penis. Then we have, so when we retract it, if it's retractable, then this is normal. Then sometimes when you retract it and you want to put it back in the original place, again it got fixed, so this is called paraphimosis. So if the foreskin is fixed on the glans penis, so this is called phimosis. If it's fixed on the penile shaft, then we call this paraphimosis. Okay. Next is we will check the glans penis for any signs of inflammation, like redness. So if it's inflamed, then we call this balanitis. If it's inflamed with a foreskin in an uncircumcised patient, then we would call this balanopostitis. Now, next is we have to inspect the opening of the urethral meatus. Now, the urethral meatus should be normally in this position. Now, if it's here on the ventral side, then we call it hypospadias. And if it's present on the dorsal side of the penile shaft, then we call it epispadias. So we have to comment on these abnormalities. So the opening of the urethral meatus now looks normal in the correct position. Then we will go and inspect the rest of the penile shaft. Inspect it for what? Usually we inspect it for signs of inflammation, signs of sexually transmitted illnesses. So we go over the penile shaft and we look for any ulcers, any discoloration, maybe redness. And then once we end with the penile shaft, we inspect the inguinal lymph nodes for any inguinal lymphadenopathy, as if we have maybe swollen nodes or any ulcers over the nodes. Okay. So this is for the penile shaft. Now, before we move to the scrotum, actually, we have to, in case we suspect there is a discharge or there is a disease with the patient, so we have to, or we can ask the patient to do it, or we can do it. So simply we can ask the patient to milk the penile shaft, then we wait for a discharge. Now, if there is a discharge with a swab, we will take it and then we send it to the lab for culture. Okay? So by this, we end up examination of the penile shaft. Next is we move to the scrotum. Now, in the scrotum, we have to first inspect, then palpate, then we do some special tests. So inspection of the scrotum, of course, we have to ask the patient to move the penile shaft away from the scrotum so that we have a good window. So first of all, we inspect the scrotum. Now, before we inspect for abnormalities, we have to look for the normal features. So what are the normal features for a scrotum? First of all, it has to be wrinkled. If you can see, the scrotum has to be wrinkled. Then the left testis has to be lower than the right testis. This is in regard to the perpendicular vein of the left testis. So that's why it's lower than the right one. Then the last normal feature of the scrotum is that it's attributed to temperature. It means that if it's cold temperature, then the dartos muscle will contract, then the scrotal or the scrotum will look smaller, and warmer temperatures, the dartos muscle will relax and the scrotal size will look bigger. So we have to take care of that, and we don't jump into conclusions that this is normal or abnormal before we relate the size of the scrotum to the temperature. So wrinkles, the left testis or the left testis is lower than the right testis, and finally the relation of the scrotal sacs size to the temperature. So having said that, we're going to look for any abnormal signs. So any alteration from these normal features of the scrotum would be considered abnormal. Then we have to look again for signs of swelling. If we have swelling, if we have signs of inflammation like redness, okay, or any effusion or swelling that we can detect by inspection. Next is after inspection, we're going to do the palpation. Now the palpation is mainly for the testis and the vas deferens. So how are we going to palpate the testis? So I have to use both my hands. So when I'm examining the left testis of the patient, I will fix the testis with my left hand. Then with my right hand, I will use the thumb and two fingers, which are the index and middle finger. So like this, okay? Then I will palpate the testis, okay? So I'm fixing it with one hand, then the other hand is palpating, okay? So at the same time, because with palpation, I'm looking for mainly tenderness maybe, and I'm looking for swellings. That's why I have to keep an eye on the patient's face in case he has any pain or tenderness. Okay? So I will palpate the testis. I'm looking for tenderness. I'm looking for any swelling. Now with the testis, I have to specifically comment on the epididymis, which is present at the posterior-superior-lateral aspect of the testis. So posterior, then superior-lateral. So it's usually at this position. So when we palpate, we have to comment specifically about the epididymis. Next is the vas difference. Of course, I will repeat this with the other testis, with the same comments, with the same abnormalities that I will look for. Then finally, I will put both thumbs like this. Then I will swipe laterally, looking for any abnormality with the vas difference. Now, by doing this, I should be able to feel the vas difference, okay, which is connecting the testis and going up into the inguinal canal. Now, this is the inspection and palpation of the scrotum. Now, next is, what if I get a swelling? Now, let's take an example. We have another mannequin which actually shows a swelling. Okay? So this is another mannequin that shows, from the inspection actually, and if you palpate it, you can obviously tell that this patient is having a swelling on the left side of the scrotum. So how can we approach this? How can we reach a differential diagnosis? So first of all, I would just like to explain this briefly on the board. Okay. So we're starting with a patient with scrotal swelling. So the first question we should ask ourselves is, can we get above the swelling? So this is the first test that we're going to do, and of course we will explain it in a few minutes. So can we get above the swelling? How can this help us? Now, if we cannot get above the swelling, then this means that this swelling is coming through the inguinal canal. So this is rather an abdominal-scrotal swelling. It's not an intrascrotal swelling. So, for example, this is most likely an inguinal hernia. So this is if we cannot get above the swelling. Now, in case we can get above the swelling, so if we can, this means that this is an intrascrotal swelling. So this swelling is not originating from the abdomen, rather it's a pathology within the scrotum. So we will do the second test, which is called the cross fluctuation test. Now the cross fluctuation test, this is very simple. This test actually is testing for a fluid. Now, we said this is intrascrotal swelling. So is this swelling, is it solid or cystic? Now, if it's cystic, then this test will be positive, meaning that if you press on one side of the swelling, you will have like a wave transmission on the other side. And if it's negative, then this means that this is a solid swelling, okay? Because it doesn't cross fluctuates. So actually this is a solid type of swellings, and most likely this could be a testicular cancer or some other pathologies. Now, if the cross fluctuation test was positive, so we can say that this is a cystic type of swelling, and cystic means that we have fluid inside. So the last test that we have is telling us which type of fluid is it. So if it's positive, then we call this a hydrocele. So the trans-illumination test, this is, as we'll show you in a few seconds, we'll shine a light on the posterior side of the scrotum. If it trans-illuminates, then this is what we call hydrocele. If it's negative, then we have other differentials or other types of fluid, for example, a hematocele or a varicocele. Okay? So this is basically how we approach a testicular swelling. Now, let's see how we clinically perform these examinations. So let's go back to the mannequin that we have, which has the swelling. So first of all, we said we have a testicular swelling. The first question we asked ourselves is, can we get above it? So this is the swelling I have. So I will go and try get above it. So can you see I can get above the swelling? So this is actually an intrascrotal swelling. If I cannot, and the swelling is continuous inside the inguinal canal, then we call this an abdominoscrotal. Okay, so the first question is, can I get above the swelling? The answer is yes. So this is an intrascrotal swelling. Okay, so the second question I have to ask myself is it solid or cystic? So how can I do this? By doing the cross fluctuation test. So the cross fluctuation is very simple. So this is the swelling I have. So I will press, again with the thumb on 2 fingers, on one side of the swelling. Then I'm going to wait for the wave transmission on my other hand. Okay? So by pressing on this side, I can actually feel the bulge on the other hand. So this means that I had a fluid, and when I pushed it, it was displaced to the other part of the scrotum. So that's why I have a fluid. It's not solid. If it's solid, it wouldn't displace with cross fluctuation. So actually, the cross fluctuation here is positive. So I have an intrascrotal swelling, which is cystic in nature. Now, the last test I'm going to perform is, as we said, it's called the transillumination test. Now, the transillumination test is simply we shine a light, okay, with a torch. Then we have, of course, to dim the light of the room. Then I will place it in the posterior side of the scrotum, and then I will wait for the scrotum to transilluminate. Of course, transillumination is usually it's a red light, so actually you will see the scrotal sac is glowing with light. Okay. Now, if that is positive, then it means that we have a hydrocele. If it's negative, so we can say it's negative in our case because we cannot see a transillumination, then it's other types of fluids. Okay? So this is simply how we approach a testicular swelling. Of course, this is the end of the examination, but of course at the end we have to thank our patient. So thank you, sir. I'm going to relay these findings to my senior doctor. Thank you very much. And of course, we drape our patient, we thank him again, and we end the examination.